Hello, I am Ignacio Matsantos. Welcome to the second edition of the iCTO meeting, the meeting of CTOs of the Iberian Registry. These are more than 30 institutions that have been collecting cases of chronic total occlusions, more than 2,000 now. And today we are having an amazing course with live cases from Hospital Puerta de Hierro in Madrid and Hospital Clínico Universitario in Valladolid, and with an excellent panel that will be presented in a few minutes. I want to share with you the program. You can see that we will be working all the morning and at every exact hour. So at 10, at 11, at 12, we will have presentations from our speakers. But now I want to give the word to my colleague, Jose Antonio. Jose Antonio, please.
Good morning, Ignacio. Well, welcome everybody. I wanted to say hello to the people who are watching us in Wonder Medical. I hope there are a lot of people watching this webinar. I think we have, as Ignacio said, we have a great panel with people from Spain, Portugal, and France. We have two difficult cases, but very interesting one. I think we all are going to learn a lot of the cases. And also, I would like to thank our sponsor, Boston Scientific and World Medica, for giving us the opportunity to develop this webinar. It's the third one. We started on 2020, and this is the first one of 2021. And I think the three of them has been very successful. I hope this one is going to be also interesting. I would like to present two short messages. I'm going to show you, taking the opportunity of this webinar, to present two slides regarding the Spanish registry of CTO. So I'm going to share the screen now. Okay. So the Spanish registry of CTO, it has been created 3 years ago, more or less. It was coordinated by Ignacio and me, and in these 3 years the registry has already included 2,500 people, procedures in this case. So I think it's a great success of the registry. It's a lot of work to do. We have many projects. We already have made several projects. We have made some publications, but we have a bright future with the registry, I think. And it's a lot of work to do. So we have decided to create a scientific board that is going to help us, and their mission is to first to propose new studies regarding the registry, to supervise the projects that are ongoing, and I would like to present our colleagues of the scientific world. As you can see, they are very young people. They are leading experts here in Spain in CTO procedures. And I would like to present Ander Regueiro from Hospital Clínic in Barcelona, Dr. Alfonso Jurado. He's working in Hospital La Paz in Madrid. Doctora Soledad Ojeda from Hospital Infanta Sofía in Córdoba, in Andalusia, and Doctora Nieves Gonzalo from Hospital Clínico in Madrid. We are sure they are going to do their best. They're going to provide a very strong scientific support to do the registry, and we hope we are going to do great things with them. And the last thing we wanted to present to you is the first manual on CTO procedures in Spanish language. We are proud to present this manual. It took a long to develop the manual, hardworking, but finally it's here. It will be available soon. We are proud to say that it's prefaced by two of the greatest CTO experts in the world, that are Masai Yamane and Stefan Rinfred. It has 15 chapters and online supplementary material, and it has been the effort of best-in-class 34 authors from Spain. And I think it's going to be a very useful manual mostly for people who's Spanish spoken people. I also would like to thank Boston Scientific because this manual has been created thanks to a grant from Boston, and I think this is also well, it's an honor that they have trusted us to create the manual. Well, and I don't want to say no more. I'm going to introduce you to the chairman, Dr. Pedro Cardoso from Hospital Santa Maria in Lisboa. He's going to be the chairman. He's going to coordinate all this webinar. And he's going to present to you the panel. So, Dr. Cardoso, if you're ready, you are in charge right now.
Good morning. It's my great pleasure to be moderating this meeting, and so I would like to thank Ignacio and Jose Antonio for this kind invitation. I would like to present our speakers who will also be our members from our panel. So they will be also the panelists commenting the cases. And so beside Jose Antonio and Ignacio, we will also have Javier Colea, very known from Hospital Puerta de Hierro. Then Dr. Alfonso Jurado from the Hospital Universitario La Paz in Madrid. Dra. Soledad Ojeda de Córdoba. Dr. Ander Regueiro, de Hospital Clínico de Barcelona. Dr. Alfredo Redondo, Hospital Clínico Universitario de Valladolid. Dr. Pierre de Haro, de Assistance Publique des Hôpitaux de Marseille. Dr. Ana Mas Serrador, de Hospital Clínico Universitario de Valladolid. And finally, my friend, Dr. João Silveira, from Hospital Santo António in Oporto. And so we will. I think we should proceed to present the first case. So maybe we could connect to Valladolid to hear the first case. Can you hear?
Okay. Yes, I can hear you perfectly.
Okay.
We are still preparing everything for the case, but first of all, I'd like to introduce the team, and then I will give pass to our fellow to present the case. So we have Ana Serrador, my colleague, who has been preparing the access for the patient that are already in place. We have also with us Jesus, who is the nurse that is always with us, or almost always with us, in the CTOs. We have Miriam with us, who is our nurse, all the technicians. Nerea, we have Nerea with us, that will be preparing everything. And now I'm going to ask Sandra Santos, our fellow. Sandra, are you there?
Yes, I am.
Okay.
Let
Please,
me
Sandra,
prepare
can you start presenting the case?
Sure. Good morning, everyone. So this clinical case is about a 68-year-old male. He has hypertension, type 2 diabetes mellitus, and dyslipidemia. He's obese, and he has a chronic coronary syndrome. In 1993, he debuted with a non-STEMI. He suffered disease from the LAD, and a PCI was made over there. And he was clinically stable until 2013, when he suffered another non-STEMI. And in this case, left circumflex and right coronary artery were treated percutaneously. The patient has paroxysmal atrial fibrillation with an ischemic chest Basque score of 4 and a bleeding score has bled of 2. And now, in June 2021, he presented a typical chest pain with an ECG with ST depression in precordial leads. The echo showed a mild reduced ejection fraction with apical hypokinesia. In his blood test, we observed a significant rise in troponin, and his renal function is normal. Patient was transferred to our cath lab in the first 24 hours. And as you can see, he presented significant lesions over the proximal mid and distal LAD, and also significant lesion in the distal left circumflex. When contrast was administered to the right coronary artery, mid CTO was observed. So in this index procedure, patient was treated percutaneously over the LAD and the left circumflex. After we finished the case, we studied the right coronary artery and we analyzed the CTO. We categorize it as a J score of 1 because the entry shape of the CTO is blunt, but he has no calcification, no significant bending, and the occlusion is short. Rentop collaterals is 3, and collateral connection grade is 1. So according with this analysis, percutaneous treatment was planned, and the strategy that we have planned is to start with wide escalation, but we consider that we will succeed with dissection reentry using the cross-bus stingray device. So now I'm gonna explain all the material that we have prepared for this case. Dr. Serrador has prepared femoral and radial right access. In the femoral sheath, it will be placed an AL 0.75 with side-hole French catheter. By the radial one, it will be a powerback 3.56 French catheter. These are the wires we have prepared for this case. We will start with a Warhorse silver wire. And afterwards, we have prepared the UDO3, Hornet 10, Hornet 14, the second wire, and the Gladius EX14. We will use the Mamba 135 microcatheter. And to increase the support, we will use the trap liner, that is a guide extension with wire trapping. As I said before, we think that we will succeed with the antegrade dissection reentry. So we have next to the table in the cath lab the cross-bus stingray that I'm not going to explain that because Dr. Amat we will explain while he's using these tools. And if we succeed and we cross the CTO, we have planned to use the Artemis balloon, that is a semi-compliant balloon. If everything is going all right, we will place the Elunir stent from World Medical.
Are you with us?
Yes.
Okay, so we just selected the coronaries and we are ready to show the first injection so you can discuss with the panel about the case, okay? We are going to do the first dual injection live.
Yeah, well, okay. Now I see the images. Sorry.
Okay. ¿Sí, no, Jesús? Sí.
As we understood, we are going to start with integrated wire excavation, but you think that probably we will succeed with integrated accession and re-entry with a cross-bus XT gray. So I would like to which wire would you start in this case?
So I'd like to know also from you and from the panel, because of course there are many options. If we apply the hybrid algorithm in this case, we can see that there is an ambiguous proximal cap. There are many branches. The CTO is not long. The distal vessel is diseased. It's not so good, as you can see. And the problem is the retro options. We don't see very well the septals because there are very good epicardial, Ipsi and contralateral. You can see that epicardial, that is coming from the circumflex. You can also see one coming from of the acute marginals. And both of them are very good to see, but maybe not so good to work. So my approach initially, as Sandra has been mentioning, is trying integrate wire escalation with Mamba microcatheter and a Judo 3, which is a moderate weight wire in the tip. So I want to explore the proximal cap with that. Maybe we succeed and we finish the case in 5 minutes, but I don't think it's very likely because there is a bifurcation also in the distal cap. The distal vessel is diseased, so we will see. Vamos con el Mamba y la Judo 3.
Okay, so the other people
Mamba normal
in the panel, what do you think about the strategy? Would you follow the same strategy, or would you? Because you can see there is a quite big epicardial arising from circumflex that could be considered. I don't know. What do you think?
First of all, do you think that we should try to do another projection just because the proximal cap seems ambiguous, but it maybe in another projection like a spider or something like that we could separate and this capsule from this marginal, the acute marginal. Maybe we could and this sometimes.
Hacer otro cine bilateral.
Vale. ¿Lo damos a la vez? Va a hacer otro cine.
So we are going to acquire another angio following your suggestion, but in this case I prefer cranial.
Vale.
Ready? Go. Okay. So there is some more information here. See the origin of the epicardial branch for the circumflex is a little bit strange. It's very, very proximal. It comes from below around the artery, so it's not so simple as it may seem. But the CTO is not so long. That's good. That's the only good thing that we have here.
Okay.
Le dejé la vía totalmente alicatada, Full metal.
I don't know if the panel is already connected.
Well, I asked the panel just to know if they would suggest another strategy. I don't have any.
Yes, we hear you.
Yes. Okay. So very, very complex case. Ignacio, you're right, and I think it was quite nice to start with 8 French, and I'm not sure what you had in mind to go with 8 French integrate, but you know, it's exactly the hybrid algorithm here. There, if you're a bit lucky, you will succeed integrately to find the cap. But you don't have a good retrograde, and either ADR doesn't look very easy because the vessel is quite diseased. So the real challenge there will be to find your proximal cap and to puncture it. I may think the Judo 3 will be may not be strong enough to find the cap, but you can start with it and try to find your way, and maybe use IVUS if you're comfortable with to really define the cap if you struggle. but it will be challenging. And the proximal cap definition clearly will make a difference, because if you don't find it, the retro options are really poor there.
Thank you.
I think it's a very good suggestion. It's a very good suggestion. I'm trying to install a trap liner and then try to advance the wire. Probably it's going to prolapse to the branch, and if that happens, we will do the IBUS from the branch following the Pierre's suggestion.
And what do you think about the septal branches? There are several of them, but of course there is not a clear connection with the septal branches, but it's another option maybe to do a selective injection of the septal branches. So there are many possibilities here. We have the integrate with the dissection, the septals, epicardial. So I think the problem here is which to choose first. Or second, because if you fail in the integrate approach, I don't know if you would go to septals or you would try the epicardial. I would like to know what the panel thinks about this.
Antonio, I think the problem is the second option. The first one, I agree with Pierre and Nacho. Probably the anterior wire escalation is a short occlusion. All the options have pros and cons. It's a very ambiguous proximal gap. But the distal vessel, as Pierre said, is quite diseased. So anterior dissection and reentry is quite difficult. And all the septals, I think, start in the stent segment. So it's another problem. So I would start, as Nacho, with anterior wire escalation, probably IBUS based. And afterwards, I don't know, probably dissection reentry.
I agree that probably the retrograde option would be the last one.
I agree with you. I will try antegrade wire escalation. I think is the best option at the beginning. Probably if the cut is very ambiguous, puncture the cap guided by IBUS is a good option. And my second option will be a retrograde approach. I will try the septal channels, because although the connection is not clear, sometimes if the epicardias is very potent, you can not see adequately the septal branches. The last option, probably the epicardial, because it's tortuous, it's big, but a bit tortuous. Antegrade dissection reentry, in my opinion, the problem is the distal vessel. It's not very adequate for antegrade dissection reentry, in my opinion.
We
risk to re-enter in the branch.
The thing is that ABR in this case is not a very good option because of as you said, the distal vessel is very diseased, and just you have a good distal vessel, but it's after the bifurcation, and also you have several branches proximal to the proximal cap. So I think ADR will be probably the last option, and I will try also if where escalation fails I will go through the septal channel. So the thing is that it may be appealing to go with IBUS puncture of the proximal cap, but the angle of the branch proximal to the proximal cap, it's not good to advance an IBUS. But hopefully you can go with a wire escalation and go through a channel.
Yeah, actually, we could not see how poor the distal vessel was until we had the dual injection. So now, as you mentioned, it's a challenging case. We risk to have the re-enter if we do it very distal to the crux, and then lose the PL. So that's an actual risk. We are going to try antegrade, as you suggest. And if that fails, probably trying retro is a good option, but I'm not very confident in these septals. Although probably they are better than what we can see, because with this bicepicardial, the flow is diminished, but the connections exist. So this will be also our strategy here. But if septal fails before going to epicardial, I would try dissection reentry.
Probably you have, Nacho, 50 millimeters to re-enter in the
just one second. I'm going to move to the cath lab with your permission. So I see you in a few minutes. Okay.
Well, let us know when you will be ready to present the second case.
Sí. Vale. Vamos a hacer un cine aquí retro.
So, does anyone make another comment from the panel?
The top liner is 7 French, Nacho.
The guiding is the 8, and the left one, the trap liner is 8 French as well.
8 French.
So here it is very useful for crossbow stingray if required. You can see I have advanced my my Judo 3 wire, and I'm not sure if it's in a branch or in the main vessel, but probably if it's in the main vessel, it's in a false lumen. I'm trying to redirect here.
I would like you, Ignacio, to comment on the use of the 8 French guideliner. I mean, it's just not to have some more support, but also if you advance for the cross boss, you would like to have an 8 French. Is it true?
Here is not so much for the support. It's not so much for the support, but mainly for the trapping function. Okay, because if we with 8 French we could use trapper or a standard balloon for the trapping, but it's extremely comfortable. And as you can see, the right guiding catheter is not so well intubated in the artery. I have been having problems. I'm not going to put the trap liner very deep into the coronary, but I think it's doing a good job here for the support. Was not intention. Oh.
And you will, if you go to a cross boss, you will also have the chance to protect the subintimal space.
Yeah. What do you think about my wire now? Is this a branch or a subintimal trajectory?
Seems like this.
We'll go in with another projection, probably right, to see the direction of the wire.
Vale, un test, Jesús.
Or left, yeah.
Wow. Very close.
Not too bad.
It's out, no? Subintimal space.
Could be.
What feeling do you have with the wire?
But here is a branch. Here is a branch, yeah.
Yeah, and the other thing, Nacho, what do you think about putting a wire in these proximal branches just to guide you?
You mean for anchoring? Or you mean in the proximal gap?
As a marker.
As a marker, exactly. So you know where you have the proximal gap.
Yeah, it's a good idea. I'm going to see where I am because I felt something with the wire test. I felt like we cross or puncture or perforate something. Okay. Now it goes all the time to this branch. I'm just trying to reposition, and then I will try what Anders suggested. But this is the Mamba. Mamba is a catheter for support, more than for navigating small branches. I think here, okay. I feel the calcium, so for every step. I'm going to change up my projection now. Un test, Jesús. Okay. Seems okay.
You're really near.
Yeah. We'll keep advancing this wire and see. Otherwise, maybe you're in the body of the CTO, so you can change your wire if it doesn't progress anymore, or if it doesn't reach the good limit.
What wire would you escalate to a Gaia or Judo 6?
Yeah, from a Judo 3, I think I would go to a Gaia or a Gladius. If you, as a first step, just to try to find a way into the through lumen, and then Judo 6 is really the next step.
Okay, then I'm going to do a cine here to see exactly where I am, and maybe then escalate to a Judo 2nd. Vale, cine.
It's quite reassuring.
No, Gaia 2nd. So I'm in the structure. I'm happy with the position, but it's true that now we need something else. And here is the problem, the bifurcation distally. I'm sorry, Ander, I'm not ignoring your suggestion of positioning a wire in a proximal branch, but I'm just in a step where I want to try to advance a little bit more. And if I'm not able to, I will maybe position a wire that can be helpful later. Also, Dr. Cardoso suggested me to inject in the acute marginal with a microcatheter. And that's a very good suggestion to save some contrast because we are injecting from the left. If the case is going to prolong, we might do that.
Yes. Now, Sorry?
Can you explain it? So you advance your mamba, do you rotate it or do you just slide it on your wire? Because it's making, it's just as a proximal cap of the CTO, so it may be a bit challenging to advance it.
Yeah. So I'm going to show it if you. So I do very small rotation, fixing the wire, and advance. You see, it advance. I'm going to increase my support a little bit. Okay. So in this point, small rotations because we have not crossed yet the CTO. If we have crossed the CTO, we can be a little bit more aggressive.
Yeah.
Espera un segundo.
It's critical to just put it in the CTO body and to pass the proximal cap if you can.
Yeah. So I think I'm going to remove here my wire. Always under scopy, the first millimeters, because it can be stuck in the cap. And I will remove. And
so will you choose now to try to penetrate the distal capsule?
So I decided to try now with Gaia 2nd to direct the distal cap because the visualization is quite good. I expected poorer visualization. Vale, toma.
¿Lo tienes aquí, Jesús?
Okay. Vale, rotor. As you know, with Gaia, torque is very important because here the transmission of the movement is 1-1. And I really want to have the... Si quieres, pero uno de los otros para luego. Si quieres, a ver.
A lo mejor está un poquito cerrado.
Okay. Okay, we are in cranial. Let me see the last cine that was in cranial. We were a little bit more advanced. And it's not so clear where the distal cap is because it's not in the same plane as the wire. So maybe there is still a bending towards back. So it's not so obvious. You can see that I'm really pushing, and here the trilinear is being useful. Okay. This has gone somewhere. Let me check test. No. Okay, let me remove, point out. Okay, there is better for me. I will advance the Mamba a little bit and all the system.
Oh, se coló.
Sí. Entonces, ¿el de izquierda se ha salido o qué? Está un poco hipotenso.
A lo mejor está demasiado metido en la izquierda.
A ver, vamos a poner Nora 1, test. So you can see the pressures. Patient is a little bit hypotensive.
Mira ver los ceros, Nacho. Mira ver los ceros.
We are going to check if this is correct. Vale, ceros, por favor.
And the ECG has changed as well.
Sorry?
The ECG is different.
We have not checked yet because we just administered the heparin after the punction, and we will have check it now, I think. Okay, we can have the first one now. Vamos a sacar un ACT.
Nacho, I mean the electrocardiogram is different now.
Yeah, I saw it. You saw it's when I was more selective in the right. Okay, let's see what happens here.
Pónselo, Nerea.
A ver, suero rápido, la Nora. Vamos a hacer un cine. I'm going to check the right, the left coronary. Cine. Flow is a little bit slow.
Vamos a sacar una CT, pon la Nora 2. Sí, pon la 2. Sube un poquito
Okay.
más la Nora, ¿vale?
I'm going to remove my catheter from the left a little bit.
Dame para separarlo.
Vale.
Dame una
Vale, tenemos que echar un vistazo. We are going to check with echo just in case. I think it's better if we move now to a talk. We are going to solve this solution. Nora?
Okay.
Y el eco, por favor. Vale. We are going to check everything and see what's happening, okay? So maybe we can reconnect.
Okay, so we will maybe we will connect now to Puerta de Hierro, and then we will reconnect. We will be back to you in a moment, okay? Sí. Vale.
Okay.
So let's connect to Puerta del Hierro.
Can you hear me?
Yes.
Well,
Hi.
welcome everybody. Hello, Pedro. Hello, Ignacio. And welcome to Puerta de Hierro. Let me take the opportunity to present the team that's working with us. Well, José Antonio, you know him quite well. He's the co-director of the course. Ithia, which will be our nurse. I would like to say the same as Ignacio, that we have a regular nurse for CTOs, but we do not. But I think Ithia is a great professional and will be of sufficient help. We have Pilar Cañas and Maria Fernando, who is our fellow, and he will be helping us with taking care of the patient. And the echocardiogram, if it be needed, I hope not. And I take the opportunity also to present our former fellow, which is Carlos Arellano, an excellent interventionalist, and he will present the case, and then we will talk about the findings that we have just made. Carlos, maybe you can come and present Okay, so we have a 72-year-old man. He's a hypertensive and former smoking. He was first admitted in our hospital in June 2020, and at that time he had an acute coronary syndrome with minor troponin changes. And this is basically what we found. He was an advanced atherosclerosis, as you may see, both in the left and right coronary artery. The right coronary artery, which is the focus of our attention, and this is what I would like to explain to you, has a severe lesion in the very proximal. Please go back. Okay, so we have put in play the right coronary artery. We have a severe lesion proximal in the right coronary artery, and then a complete occlusion after the acute marginal branch that you can see. The distality of the right coronary artery was seen from the left, mainly through a septal branch, which is a large septal branch with many small branches, which is not good from our point of view, from the interventionalist point of view. But I think one of them could be, and that is what we thought at that time, could be used for a retrograde approach. Next slide, Carlos. So that's what we did. We attempted the retro approach because we considered at that time that the anterograde approach was too difficult and there were small chances of success. And this is, you see a distal septal that was, there was no connection. Next. And we did try several septal branches and several sub-branches of the first large septal branch without success. Well, at that time, what we did is to treat the proximal and just consider that maybe we could obtain some benefit from the mid portion of the right coronary artery being revascularized. And after a long session that you can see, 94.5 minutes, 1 year ago, 6 grays, and this is the map of the projection, mainly left anterior and cranial, concentrating. Well, after that long procedure, we failed. We failed from the anterograde approach also. Next. And that the patient was managed medically. He was quite all right with effort angina, and until June. And in June, he was readmitted because of a prolonged chest pain without not related to exertion. And what we found was that the stents, the proximal stents were totally occluded. We could still see the same collateralization to the distal right. And I would like to point out that the distal right is a very diseased vessel. I don't think it's good at all for anterograde dissection re-entry. What the operator did was an urgent procedure early at night. Next, what the operator did was to try to open. He interpreted the clinical picture as being due to stent thrombosis. There was just 1 year, just under 1 year of a stent position. And with a conventional C-on wire and a microcatheter and a JL4 in an urgent procedure, Dr. Adeltrigo, she tried to open the artery, and she did cross the stents, but next, without success. So this is the patient. We talked to the patient afterwards. The patient has limiting stress angina. He has the inferior side, the inferior part of the heart is positive, contracts correctly, so it's viable. And we are in this position. I will pass over to Jose Antonio that will discuss what we are planning. I would also like to stress one thing. I mean, we did look at the patient at the back, and there was no side effects, no reddening, no inflammation related to the previous procedure. So We proposed to him, and he was very, very eager to try another because he really is limited with angina. And this is what the point at which we are at right now. And I would like Jose Antonio to discuss what is the plan for today. By the way, my name is Javier Goicolea. I didn't present myself. I thank Pedro for saying I was well known, but I will be the second operator, and Jose Antonio will be the primary operator. And that is another thing that we have learned. It's better to have two operators, two experienced operators working in these long procedures, because there is the fatigue factor that maybe in some way minimized with two operators. Okay, thank you.
Okay, thank you, Javier. Well, as you can see, it's a quite difficult occlusion. It's a second attempt, but the reason to try a second attempt, even taking into account the complexity of the CTO, is that the patient is very symptomatic. He has angina with every time he walks a few meters, so he's very symptomatic, and that's the reason why we are going to try the second attempt. As you can see, the first attempt was tried retrograde through they sort of through several septal branches, but they didn't cross. We think now I'm going to show you that we think there is a good septal branch here. I'm going to move cinema, so you can see there is. We think there is a quite big septal branch. The problem is that it's very tortuous. Even there is a segment with a corkscrew, and at the end of the septal branch, there is a acute bench. So it's not a very easy one. I think we have calculated the JE channel score, and it was.
We can show the presentation.
Yeah, maybe we can show the JE channel score, Carlos.
Can we switch over to the presentation? We want to see the last slide. This is the last slide, and this is an attempt to categorize the difficulty in the retrograde approach, both through the septal and non-septal approaches. Of course, the validation is not complete, it's not optimal, but I think it summarizes quite well the majority of issues that can limit the accessibility from the retrograde approach, both the reverse bend, the continuous bends, which are pictured in the C, and the corkscrew. The corkscrew applies basically to the non-septal branch, at least that is what the J channel score says. And from this point of view, it would be an intermediate difficulty. But we would like you to discuss the approaches. What would you do from this initial, and then we'll show you what we've done and what we've seen right now. Okay, Pedro, it's up to you and to the panelists.
Okay, so I think it's a quite challenging case, and the septal doesn't seem so difficult, but it's true that it was already tried and it was not possible, so I think it's quite a challenging case. I would like to hear from the panel if everyone agrees that it's a primarily retrograde case, or if someone suggests another strategy.
Pedro, I would like first to show you, because there has been a major surprise when we have done the angio.
Okay.
Because if you remember the last procedure, there was an occlusion of the stents in the proximal segment of right coronary artery. our colleague did a dilatation with balloon, and as you can see, the stents are now open. So it was like an investment procedure, although that was not the aim of the interventional cardiologist. But now we have a little advantage because we already have that proximal segment open, and now I think we have several options here. I would like to hear the panel. What do you think? You will try antegrade or you will go directly retrograde?
Antonio, sorry, we haven't seen the case because of technical problems. So just to recall, you did a first attempt by antegrade and retrograde approach, and it was an unsuccessful attempt. And we can see the distal vessel. So if you can show us again, because we haven't seen it.
Okay. Maybe we can show, Carlos, the last angiography that was performed 2 weeks ago. So we are going to show you. There was a first attempt last year. They tried retrograde and antegrade, and successfully they deployed 2 stents in proximal segment of right coronary artery.
If I may, Jose Antonio, this is the... Now, could you go back, Carlos? Go back. Okay, the first... Okay, this is the initial situation 1 year ago.
Mm-hmm.
The right coronary artery was treated in the proximal portion. That there were 2 stents put in place, but the CTO was not successfully closed. So in this is what we have. Basically, it is very similar to what we have right now, but with 2 proximal stents, of course, in place.
So you can show the last angioplasty. It was 2 weeks ago, this one. Okay. So you see there was an occlusion of probably thrombosis of the proximal stents in right coronary artery. Left coronary artery was the same.
No, I couldn't see the imaging. You are not live, okay?
Can you see the presentation?
Yes,
no,
we asked.
Me, I can. Yeah.
No,
with
Jose Antonio Gutierrez.
no, I couldn't see.
From France, we can.
No, I can't see the imaging.
Can you or cannot?
No, nothing.
No, we are seeing the presentation with the.
It's okay. Perfect.
It's okay now.
No, it's okay. That's okay.
Okay. So that was the situation 1 month ago. Almost 1 month ago.
Previous attempt,
And
in the previous attempt, you failed some septals, and you are going to try another one, or what is the plan?
Well, it was not us, it was another colleague, and they tried several septals, but I think he didn't enter the septal that we are talking right now, this one with the bench. So I think we have an opportunity with this septal.
Yes, we have analyzed very
Carefully.
thoroughly the procedure, and I think that the sub-branch of this septal that connects wasn't attended. That's, of course, you cannot be sure because not everything has been filmed, but we have talked with our colleague, and we think we have an opportunity.
Okay.
I think it's a good case for retrograde approach because the septal channel a priori are favorable. The occlusion is large. I think it's the best option at the beginning.
Yes, it seems like the proximal capsule it's still very ambiguous, even if the stents are open. And so I think that the retrograde approach is the initial strategy.
Which is the microcatheter? and the guide wire.
Okay, yes, I'm going to tell you this. We are working with 7 French extra backup for left coronary. In the right, 8 French AL, 1 for right coronary, and now we are moving with Corsair Pro XS, a long one, of course, and we have a Sion wire just to enter in the septal branch, and then we change the wire.
Maybe you can explain the difference of the Corsair Pro XS to the former Corsair.
Un toquecito, a ver.
Es más proximal. So right now we are trying to get into the main septal branch, which is not so easy.
We are going to modify the curve of the wire.
Would anybody go integrate directly from what you've seen? Pedro?
So it's Pierre from France. I'm not sure you hear me well, but it's a good case. I agree with you. It's clearly a retro case, but usually in this type of retro case, I like to do integrate investment first. So my usual strategy is to walk integrate a little bit and to knuckle quickly if I think it's a retro case. But I always start by approaching the integrate cap, even if there is a failed few weeks ago. So, but it's not mandatory. But I like to just have a feel to the integrate before starting the
to have some work already done if you are successfully retrograde. I understand.
Well, actually, the procedure 1 month ago was limited to the septal, to the stents. Our colleague considered, and I think she was right, that it was not the time for a complex case, and so what she did was to try to open, and basically she did not achieve any flow through the stents, which is contrary to what we have right now. We have flow, not.
Can you tell me what is the cause of the primary attempt failure? Because it's very important.
The first one, 1 year ago.
Yeah, what is the failure mechanism of the first attempt?
Well, they did not succeed in crossing.
I'm not sure. I have some doubts if it is really a CTO, because it's something into new atherosclerosis into the stent, because you have did they do a lot in integrated investment in the vessel or not? I'm not quite sure of this, the cause of the occlusion.
You mean this patient has had 2 attempts, 2 PCIs, I mean. The first one was 1 year ago, and it was mainly directed to the right coronary artery CTO. And the second one was due to an acute coronary event that was 1 month ago, and it was limited to the acute occlusion of the right coronary proximal stents. The initial one failed because of they were unsuccessful in crossing the retrograde approach, and they did try anterogradely, but what I can tell you, it was done without contralateral injections. And
sure, this is very important, because we need to know what is the mechanism of the failure of the primary attempt? Because the vessel
on the other hand,
the stent
if I
is
may
open.
say, yes, and also I think we did not identify at that time the correct sub-branch of the first septal branch. So it was a long procedure done, maybe, I would say sloppy, is that correct?
Yeah.
Sorry, I think that we should now proceed to the first presentation and let us know progress.
Yes, we're going to work. We're going to work, as we told you first, on the retrograde approach, and we'll let you know if we make some progress, and maybe you can connect, and also with Valladolid we can switch from one to the other. Okay.
Yes, please. So I would like now to ask Pierre to make his presentation.
I'm sharing my screen. I think you can see it now.
Yeah.
Okay, thank you. Yes.
Okay, thank you. Thank you. So today we'll give a presentation about intracoronary imaging in CTOs and assessment of coronary calcium. So it's a basic concept, but very, very important for CTOs, PCI. The objective of this short presentation will be to learn why and when use intracoronary imaging in CTOs, learn how to evaluate the calcium and which calcium modification tool to prefer in CTOs, learn to assess your effect after a calcium modification treatment, when to upgrade your calcium modification tool, and learn how to assess your final result. So basically, you will use calcium modification and imaging in the pre-PCI, so before you put balloon or stents in, hopefully, in the per-PCI, which means just after your calcium modification, and in post-PCI. So we got 3 steps of calcium modification and imaging in your CTO procedures. So when we do intracoronary imaging in CTOs, what are we looking for? What are you looking for when you perform your PCI? So first, and it could have happened to Ignacio for his case, you may need intracoronary imaging at the pre-PCI stage when your just step is cap definition for your using of intracoronary imaging. The second use and the main use of intracoronary imaging is, do you need to modify your calcium in your CTO PCI? Am I in the true lumen proximally and distally? So can I safely stent from proximal to distal, and which size is the vessel, obviously? And do you need to stent the whole segment, or can I just balloon some part and leave an hematoma or something like this? And the third step, obviously, is, do I need to optimize my PCI? Do I need to post-dilate my stents? Are there any edge dissection after my stentings that I have to cover, or is this just hematoma and I will just leave it and it will seal quite nicely? So then 3 steps for your imaging in pre-PCI, per PCI when you're trying to implant your stent and modify your calcium, and post-PCI when you finished your case. So why the calcium matters in CTOs? First, calcium is highly prevalent in CTO lesions, and usually it's a progression of calcified atherosclerosis that lead to CTO. Calcium leads to worse PCI and clinical outcomes. So the more you have calcium, the more you will have target lesion revasc or target lesion failure in the next future if you don't modify it. You have different calcium modification strategies, and you know it. You can use cutting balloon, you can use asterectomy, and now you can use lithotripsy to modify your calcium in CTOs. And obviously, in this complex lesion where we reopen artery, we don't want this to fail again and to have some restenosis or some reocclusion. So you need to know and to learn how you could specifically use a calcium modification technique according to your CTO case you're facing. And we'll try to give some basic concept on this. So now regarding imaging, so we know that when we treat calcified coronaries, imaging is fundamental. CTO PCR are at very high risk, very high burden of calcium, likely to have a dissection plane, and we'll see in the cases today if we go for IDR or for antegrade wire escalation with some dissection and re-entry in the true lumen. And usually in CTOs, we know that the blood flow in the distal vessel is provided by collaterals, and it's low flow to this distal vessel, and there is a real risk of undersizing your stent, because what you see in terms of caliber is not the real caliber of the artery. We need optimal result, and for this, really, I think that intracoronary imaging is a game changer in the CTO patient. When I don't say you have to use it for all your cases, but if you want to improve your success in the long term, I think intracoronary imaging is really essential in this patient. So let's see now the pre-Pcie key concept for calcium. So first, when you will do your evaluation of your CTO lesion, you will have your length of calcium, obviously. You will approach your calcium arc. So do I have, like we see here, 300 degree of calcium? Do we have here 180 degree of calcium, or do we have 360 degrees of calcium, so a concentric arc of calcium? Is the calcium superficial or is it deep? So if it's superficial, as you see here, is the lumen, and it's superficial calcium just next to the lumen. Here on this panel, you can see that the calcium is distal. So you're in the CTO, it's some plaque, and the calcium is deep. So you won't touch it if you go with a hysterectomy, or if you go just with a balloon. It will be very difficult to reach the calcium. And the fourth concept is calcium thickness. Is it some very thin calcium with reverberation, which is an acoustic echo in case of thin calcium, or is it very thick calcium and you got just a black hole behind? And you know, if the calcium is thick, you will need to modify it maybe a bit more. So based on those concepts of length, calcium arc, superficial or deep calcium, and calcium thickness, you will decide which calcium modification tool you need and if you need to use it. And there is a calcium score that is found in the literature. So if your arc is over 270 degrees, if you got a concentric arch, so 360, if you got a nodule, or if you got a vessel below 3.5 millimeters, it's 1 point for each. And if the calcium score is superior or equal to 2, it's recommended to modify your calcium, so to use a calcium modification tool, and I just showed, so cutting balloon, rotablation, hysterectomy, or lithotripsy. So to be very simple and to give you a very simple messages, if you do intracoronary imaging and you CTOs and you see a calcium arch over to 70 degrees, I think you should consider calcium modification. If the calcium segment is very long, and usually in CTO is the case, and the cutoff is arbitrary 10 millimeters, I would favor hysterectomy, either rotablation or other hysterectomy device if you have access. If the calcium is thick and the lumen of the vessel is small and calcium superficial, I would favor hysterectomy again. But if the calcium is deep in the vessel and you won't touch it with your hysterectomy, you may consider to use lithotripsy as first line calcium modification. So you see that you will choose your calcium modification device, your first line, according to your intracoronary imaging evaluation, and mostly your IVUS evaluation. I will show it in a minute. So the OCT, let's go to the OCT. It's very useful and it's the best tool to assess calcium, but usually it's very easy to use in non-CTO lesions. It's more challenging in CTOs. And here you see an OFDI where you can clearly see some calcium. And now with some software such as Ultron, you will have more accurate assessment of calcium. So you can definitely exactly see your calcium, calculate your arch, deepness, thickness, everything. But OCT needs to be used with a lot of caution in CTOs before you stent your vessel. And you will be able to use OCT. I will show you in a minute in CTOs, but it depends which CTO technique you will achieve to pass your wire. And I use OCT only if I'm sure I'm true lumen for the whole vessel. So usually only in the easy case of antegrade wire escalation only. That's why IVUS makes a big difference, because you don't push contrast, you don't push anything, so you can use it even if there is a dissection plan. So now let's go to the second step of IC imaging and calcium modification, which is the Pre-Pcie. So you've done a first step of calcium modification following your your imaging, and you need to know, do I have to do more? Is this enough? And what we seeking is some fractures. If there is a concentric arch, did I fracture it? And did I increase the vessel lumen size by rotation or by cutting balloon or anything you've done? If you achieve calcium modification and if you fracture your calcium and you're happy with this, you can proceed to balloon and stent. Or if you're not happy, you think you did not modify enough your calcium, there is no fracture, still some concentric arch, you go for a second step. And it could be EVL or cutting balloon if you proceeded to asterectomy first. And this leads us to a very simple algorithm for IC imaging and calcium modification in CTOs. So two options, and we'll see today what happens. So you can go to uncrossable lesion where you can just pass your wire and you can, with very much difficulty, advance your microcatheter. And in blue there, you get easy lesion where you crossed it and you quite comfortable, you advance your microcatheter very easily. So if you cannot cross, my first approach is obviously to use asterectomy up front, and I do not image if I just pass with a lot of difficulty my microcatheter. I go for asterectomy, and then I go for IVUS or CT based on my CTO technique used for the single case I'm facing. And according to my IVUS or CT, either step 2 of modification, cutting balloon leads to Pre-Pcie in case of deep calcium, or directly go to PCI with balloon and stents. If the case is more easy and I can cross it quite nicely, I first go to IVUS or CT. I will show you a quick case just after. And then according to my IVUS or CT, I will calcium modify according to the result. So I can go to cutting, to IVL, to rota, to no calcium modification if I don't need it. Then reassess your imaging and either go to a second modification or go straight to your PCI. So these are the two first steps. And obviously, when you put your stent in, you will do a final intracoronary imaging. So this algorithm is very simple and we'll put in practice in the next slide. So here's the CTO case. So you can see from the first image there that there is a lot of calcium in the LAD, mild disease to RCA and collaterals to LAD. So this is a blocked proximal LAD, chronically occluded with a lot of calcium. So for this patient, I will go for IVUS guided CTO PCI, and I'm very likely to modify the calcium because it's heavily calcified. So pass the wire quite easily and integratedly, but very difficultly deliver the microcatheter. So in this case, I don't go for imaging first. I go for uncrossable algorithm. So this was in orange on my first slide. So go for rotablator first, asterectomy first, and then re-IVUS. And on my IVUS, I was quite happy. I had not concentric arch, and I had some fractures in my calcium. So I was happy. I could proceed to balloon, NC balloon 2.5 and 3.0. So I calculate my lumen, obviously, by an IVUS. And I put 2 consecutive stents, post-dilate and re-IVUS to make sure the result was fine. And here is the final result. And I was a nicely reopened LAD. So now we'll show you a second case briefly. So it's a CTO PCI to an LAD. So you can see we got poor dual injection, but we had collaterals from the right coronary artery to provide to this LAD. And in this case, I succeeded with antegrade wire escalation quite easily. So I went with a Fielder and then a Gaia, and I was quite happy. I had been true lumen for the wall segment. So I said, okay, delivered microcatheter easily, go for an OCT to improve outcomes in these patients. And actually, OCT was quite interesting because I didn't feel, but I created a big dissection probably during my antegrade wire escalation maneuvers. And when you inject quite hard in the LAD to perform your CT, actually I increased this false lumen and the dissection. But I was happy, true lumen proximal, true lumen distal, side the vessel. So, you know, low burden of calcium in this case. So you can see on the OCT, we had very, very few calcium. So I was happy to predilate this patient with a non-compliant balloon and put a long stent and single long stent. And and we end up with a nicely reopened LAD and obviously rechecked on OCT to make sure there is nothing more to do. So to conclude this short talk, so CTO lesions are very specific because you got a high burden of calcium, and I think we should have very liberal use of calcium modification in this PCI. Obviously, the second part is intracoronary imaging is essential if you want to optimize your outcomes for CTO PCI, because the problem is not to just reopen the CTO in a procedure, is to give plenty of years of freedom from revascularization for your patient. And IC imaging is part of CTO PCI, I think. And you've seen in this talks that you will have to select your IC imaging tool, and usually it's IVUS, but you may need OCT for some case. And you should repeat its use, so pre-PCI, per-PCI, and post-PCI. And according to this, you will select your calcium modification, you will select your balloon, select your stent. And what is important is just not only selection, is assessment of the effect. Have I provided a good stenting, a good optimization to my patient? So thank you for your listening, and I hope it's been okay for you to listen everything despite the technical problem I had at the beginning. Thank you.
Okay, thank you, Pierre, for a nice presentation. I would ask maybe João to make some short comment, because we will have to move to Valladolid. Do you want to comment, João?
Okay, so this is going to be a quick summary. Thank you very much, Pedro. Thank you, Pierre, because your talk is being very useful for this case, actually, and I will show you why. So let's summarize the case. You can see the function that my colleague Dr. Serrador did. The ProGlide, we did preclosure. So first, we have been checking the septals in case. You can see that all the LAD is stented. So it's not so simple to go through them. If we need them, we have a second septal that could be a good first option. And then here is what we already seen. What we think happened to the patient was that with the trap liner, there was not flow in the right coronary artery. And probably all that hypotension was ischemia. We have checked with echo, no pericardial effusion. When we remove the trap liner from the coronary artery, slowly the patient recovered. So we have tried, this is what you already see, what you have already seen. This is our wire while we were trying to find the place. Here you can see that in this projection seems okay, but when we change projection, it's a little bit far from the vessel. This was in the hypotension situation. You can see that now my trap liner is within the catheter. This is because we wanted to avoid the further ischemia. And we changed Judo 3 to Gaia. This is Gaia trying to re-enter. You can see it's bending. But here it could be in a good position. You can see that distally is not in the vessel clearly. So we continue trying, but we changed our projection, and we could see that it was really out of the structure of the vessel, especially here. So we pull it back, and we changed to Judo 6 wire. A little bit softer wire to trying to maintain within the structure of the vessel. This is Judo 6. This is a small bending that is in the cap. I'm not pushing here, just manipulating the wire. Okay. This is a longoscopy where we can see that the wire is advancing slowly in the structure of the vessel. And here we check the wire is not in true lumen, but is pretty much in the anatomy and in the other projection as well. And at this point, trying to understand also what happened before, we did an IVUS, also to analyze the proximal cap. The surprising IVUS was that it's extremely calcified, the artery, which by angio does not seem to be such an amount of calcium. We could not reach the distal cap with the Boston IVUS, But you can see that just proximal to the distal cap, there is a huge amount of calcium. In some places, it's circumferential, like here. Here, we only have part of the vessel with a calcified plaque. And at a certain point that is arriving pretty soon, we can see that there was a small dissection in the upper part of the image. We will arrive soon there. Probably caused by the trap liner, although we did not inject. Okay, there you can see we're pointing it. Mm-hmm. But apart from that, the vessel is okay. So we have also tried in the meantime to enter the epicardial branch coming from the circumflex. But this is really difficult to access because it's stented. It has been a while since the stent in the circumflex, so we have stopped there. The reason for selecting that epicardial branch was to reduce the amount of contrast because we have already used 300. And the step that we have decided to take now, since we cannot work from the epicardial in the right because it's ischemic, not in the epicardial in the left, instead of trying the septal that is jailed, we are going to try crossbows, and I have the crossbows on the table. So we are going to inflate our trap liner. Maybe we can zoom here just to show the tip of the... Zoom here. Okay. Many of you maybe know already this device. There is the tip is not tapered like most micros, but it's rounded, so it's a way to be atraumatic. It's coiled to the end so that the rotation is transmitted very well. Now I have my wire jailed. I will show you. This is live, and I'm advancing my crossbows. I don't need the scopy now because the wire is jailed. Okay. Vale. Desinfla el trap liner, porfa. Ya coge. Okay, and now I have deflated trap liner. Déjame cogerla a mí porque estaba muy poquito avanzada.
Nacho?
Sí.
I would like to ask a question. I don't have experience with crossbows and stingray. I would like to ask you why do you choose now crossbows and not directly stingray?
For using, we could avoid crossbows
in theory,
by doing knuckle.
Oh, okay.
By doing knuckle, we could avoid. Because you saw my IBUS could not navigate distally. So probably the balloon, the stingray, although the profile is quite good, if you don't open a little bit, it will not navigate. So you need or another micro over a knuckle or the crossbows. Since the distal vessel is a little bit diseased, if I do a knuckle, I will make a large false lumen and the re-entering will be more difficult. So I'm trying to be as less traumatic as possible with crossbows. And once I'm in the place I like, I will remove it and keep the trap liner inflated to avoid the hematoma from growing. And we will prepare together the stingray. Yeah. But let's see if we are able to advance it. So this is, okay, I have advanced to here quite easily, and now I cannot advance anymore. So now I'm going to prepare the torquer. This is the torquer from, and I just keep a short distance from here so that it's safe. It's not jumping. I fix it here, and I'm going to advance over the wire. Anna, can you hold the wire? Thank you. And very, very gently. Okay, so I'm going to try to advance a little bit my trap liner, although the patient does not like it at all. Okay, ¿tienes?
I think trap liner is very useful in this setting of to prevent the hematoma to grow. So it's a very, very good idea to have trap liner in place. In this case of diseased distal bed.
Oh. Okay.
It's difficult.
¿Puedes hacer una inyección, Jesús?
Nacho, is that a Miracle 12? the wire?
You
No.
see.
Yeah.
Right, we lost the position. Sí, rotor. I'm going to try to reposition my wire. What did you ask, Anders? Sorry.
The wire that you have in place.
It was UDO6, yeah. We changed
Yeah.
Gaia to UDO6. Yes, Jesus.
And do you use, you don't change usually to Miracle 12 or something like that? You keep the
Yeah,
wire that you
Miracle
used
here
first?
could be. The problem is that I could not advance my micro farther from here, despite the trap liner, because it's so calcified that it was impossible. And this is why I did not exchange. But since I have lost my position, I might try now with Ultimate.
You can advance that
Nacho,
with the crossbows.
Nacho, you have a small branches in distal portion of this CTO. Is it possible to use a dual lumen catheter to direction the guide wire?
That's a very good option, and maybe I will need to do it because you can see that I'm going into a branch.
You need to do some modification of this part of the vessel. You need to do knuckle and advance the crossbows or directly the stingray to do the re-entry. This is clear. You need to go forward to orient the re-entry in the distal vessel because you have a lot of calcification.
My only concern with dual lumen is the navigation, because here you can see I cannot advance any micro.
Probably it's not bad.
I was going to say that maybe to cross with the dual lumen, you must modify the proximal capsule with the balloon, and then you can advance.
You see the pressure is again falling, so I have to remove my trap liner from here.
Yeah.
Okay, vale. I'm trying to change the position, so I will advance another micro. Vale, inflamos a 14. So I'm sorry I interrupted the questions to Pierre. Maybe you still have some time yet to...
No, it's okay.
Sí. Vamos a meter un Sasuke. So we are following your suggestion and trying to advance a dual lumen to see if we are able to cross and change, do a dual wire, parallel wire modified technique.
What is your experience with the crossbows in heavily calcified lesions? Because sometimes it doesn't work so nice.
If it's bended, the artery, normally not so good because it's like a block and you lose your force. It's bending like that. But if it's quite straight like this one, although there is a curve but it is wide, normally it works properly even with calcium.
Yeah, it goes subintimally. And,
I agree. I was thinking it would work there, but did you consider changing your microcatheter to something like a Corsair or a Turnpike Gold or something more penetrative that you may be possible to advance the calcium?
Yeah, but for that I need to have my wire farther from the occlusion.
Yeah, but probably the most safe way to do this is to do an echo to overcoming this ambiguity and this uncrossable lesion. Probably it's a safe way to do the procedure.
So I'm going to just try to reposition another wire.
You're almost knuckling. It's almost time to knuckle.
Yeah, and because if you knuckle, you can always use after the crossbows just to finish the dissection, and you can dilate the proximal part, so it will be easier to go with the crossbows. But
una ultimate.
Yeah, probably the parallel wire with that branch will work. So.
Well, maybe we could see if there is some progress in Puerta del Hierro, and then if you have some news here, let us know to reconnect. Do you agree?
Okay, perfect. Thank you.
Hello, Pedro. Do you hear me?
Hi.
How everybody?
Yes.
Well, we've done some work. We are where we want to be. We have not yet crossed to the right coronary artery, but we are in the branch of the septals that we want to be. It has been a hard work, I can tell you, because there was an acute angle to. Here we can see it. It was difficult, and with conventional wiring was impossible, or at least would have taken us much more time. So that was a CM wire. Next. So what we did, we put in place a dual lumen microcatheter. This was a Sasuke. Next. And with this in place, and you can see the takeoff of the septal that we did want to use. It was relatively, it looked easier than it actually was, but it was relatively easy. So that's what we did. And then that was this was the position. So what we did, we took out the distal wire, leaving in place the septal one, and we did it with the help of a trapping balloon.
A trapper, yes. With a trapper balloon.
With a trapper from Boston Scientific.
We did the interchange.
And like this, we could do safely the interchange, and this is the point that we are in at right now. So I can tell you we have changed the microcatheter, so we could have used the Sasuke. It does travel quite well, but we prefer to use the Corsair that we had, the Corsair Pro XS. And next. So you can see the corkscrew of the septal. This is where what we are negotiating right now. Next. And these are the bends. We are at this time with a Suo wire. We thought the particular characteristic, the lack of tip force and the flexibility of the Suo wire would help us, and this is where we are at. Jose Antonio, now you can go live. And
I think, as you can see, I'm going to move to the first angio, the entrance of the septal branch. I think this may be the key for the failure of the first attempt, because we checked, Javier and me, the previous procedure. They didn't enter in this septal because, as you can see, it's quite difficult to enter. It has you have to do a very sharp angle to enter in the septal, and when we have, it has been difficult. I think this was the key, that they didn't cross the septal. And now we are in a difficult point also because we are right in the corkscrew thumb. So we are trying with a Suo, and maybe if we don't cross with Suo, we can try another wires. I don't know. I would like to know, Pedro, from the panel, which wire they will use if we fail with the Suo 3?
Yes, does anyone want to suggest another wire from the panel?
I would do a selective injection by the micro and then choose the wire, probably Cyan Black, or I don't know, it depends the position.
Jose Antonio, another option is Samurai RC.
Yes,
Collateral
injection would probably help.
Yes, I think that is a very good option. I think we're going to do a tip.
Move backwards a little bit, and we are going to to do the tip injection. Okay.
I think in this case you need to keep in mind that it's very important interaction between microcatheter and the guide wire. I think the guide wire is too far from the tip of the microcatheter, and probably in this case, when you have a lot of tortuosity and cosq, probably the integration between caravel, this is more flexible because you don't have calcium in the tortuosity. The interaction between caravel and sewer probably it's the perfect combination for to cross the donor vessel.
Thank you, Joe. I think that's a very good suggestion, but we are not at that point because we haven't yet crossed with the guide wire. So I think all the suggestions were useful. What we are going to do
another option is to perform a tip injection because you need to define where is the connection, or to do directly with the sign black. It stays probably it's not very recommended, but it's good. It's safe. Sometimes works very well.
So yes, sorry, I don't have experience with the Samurai RC.
Problem is to cross with the wire.
It's good.
Several cases are very good result because sometimes suo is not enough strong to cross. When the septal is very tortuous, and this case Samurai RC is a option or other alternative. We can check.
Okay, we already did the injection. It was, you can see there.
But we can't see any connection.
No.
Hey, you have some connection.
No, I don't see any.
Antonio, if you remove the microcatheter, you can see more septal.
This is not the connection you saw before in the...
So maybe we can go back with the microcatheter.
Yeah, this is the first branch, not the second one.
But there are a lot of bifurcation. Probably it's better to personally.
So the more branches you have, the more complicated you get.
Vale. Dame una Sion Black.
Yeah, this is a good option. For me, that's a good option.
Okay, we are going to try the Sion Black because the feeling is that in the corkscrew, the suo has not enough body to cross. So we are going to use the Sion Black, which has a little more stiffness. So well, it's difficult to say a priori because it's difficult to know if which wire is going to be successful. So it's a question of, it's a matter of trying several wires, depends on each case in our experience. Also, as I don't know who said before, the microcatheter also is, you don't know if it is going to cross. Sometimes you have to try another microcatheter. Maybe in this case, if the corsair doesn't cross, Carabel would be okay. It's difficult to say, so it's a matter of trying.
Yeah.
Yes, but my option here would be probably to go with the silent black as well. But maybe I lost something because I didn't see if you pulled back a little bit the microcatheter and then you see a connection, because in the first injection we couldn't see any connection. Maybe I'm wrong. I couldn't see.
We did pull back a little bit.
Yeah, but yes, in the first injection we see the corkscrew, that is the connection. Maybe I don't know. Maybe online you don't have the enough quality of the video to check it. But here we can see a connection through a corkscrew segment.
So what we can do, Jose Antonio, right now is to do an injection, a full injection through the guiding catheter.
Yeah, I'm going to
let me
advance
show
a little bit there.
our panelists where we are.
I think it's true that sometimes it's a surprise, and the microcatheter that crosses, it's not the one that you were expecting. But I have a very good experience with the Corsair. Sorry.
So, Pedro, you can see there is a connection. We have gone back enough. But there is a myriad number of channels, and we have to find the correct channel. That I think is the basic, and that is the reason for the previous failure.
I can see it quite well now, but I was saying that I would doubt that if the Corsair, after crossing with the wire, if the Corsair Pro XS doesn't cross, if the Caravelle would cross, because it's a very, very nice microcatheter, the Corsair Pro XS. And
yes, the main difference is probably you need to have some forceful negotiation this towards vessel. At that point, probably the spin like microcatheter is better than the push like microcatheter. But again, the interaction between Caravelle and Pcie Black, it's good.
Si no te pasa ahí, vete para atrás y busca otra, porque hay varias conexiones.
You can try surfing.
Yeah, that's what we are trying to do.
But more push quickly. Probably it could find
we prefer to be gentle with the septal.
I agree.
We are the Japanese school, you know. We are very we are very calm. We have plenty of time, so.
So, can we see if there is some progress in Valladolid? Maybe
that's a good idea, I think.
Okay. Hi, Ignacio.
Hello. So, what do you consider a progress?
I think that it was already done.
If the patient says this is good.
Yeah. So we have tried the Sasuke. Actually, we have the Sasuke in place and an ultimate wire, but it was impossible to advance through the occlusion. So it went to small branches, false lumen, and we decided to try, as Anders suggested in the beginning, with the septal. We wanted to go for the second septal, but it's diseased in the origin, and they are all encarcelated, and we have been able to enter the first septal with a cyan blue, and we have in the next one cross the struts with a Caravelle quite easily, honestly, and this is exactly where we are now. So we have the tip of the micro, and I'm removing my cyan blue and trying with the cyan. As I mentioned, we tried before, I have not shown it, the epicardial from the circumflex. It was not to treat, just to inject contrast to the micro, and it was impossible after a few minutes to select that epicardial that is encarcelated from an old stent, which means that probably it's well endothelialized in the origin, and so we forgot about the epicardial from the circumflex. Okay.
Did you only try an ultimate in the side port of the?
Yeah, there it is. That's the ultimate from the side port of the Sasuke, and that's the further point that we were able to advance. The Sasuke was coming back all the time when we tried to push more. We tried to reposition and turn the Sasuke, but as you know, we cannot advance the trap liner because the patient becomes ischemic, and therefore we have not support to advance anymore. We could have tried a hornet, a tougher wire, with more height in the tip, but we decided to.
Dilating the proximal capsule with a small balloon just to be able to advance the Sasuke?
I will leave that as an option if we are not able to advance from here. Vale, vamos a hacer aquí un cine. Okay.
And does anyone want to suggest something from the panel?
Yeah, no, I agree with the strategy that is being done to this patient. I think you have to try the septal. You have to keep the safety as the first plan for your CTO PCI. Integrate your next step will be a knuckle if you've not done it yet, but I think it's the next step. And a retro, the epicardial is very challenging, very risky. I would map 1, 2, 3 septals, do my best, maybe use a CO to optimize my chance of crossing. And if I fail the septal, I won't go for epicardial and go a little back to integrate, to try to go in the vessel structure with a knuckle. But it's a very complex case.
Yeah, I agree. It seems to me that the epicardial is a very risky option.
Yeah, but if you want to finish the case, you need to be more aggressive because it's a complex case. It's not. I think you need to work probably more aggressively in the integrated fashion. But because at the end, probably you can do some investment procedure. You can, if it's not bad to keep it in mind. If the main point is to keep the procedure safely. It's very important because we have a lot of problems with AV calcified, RCA, ischemic with the guide extension. Okay, sometimes you need to balance very well what is the best for this type of lesion.
But I think that it would be important to be able to advance a little bit more the Sasuke, and it's the risk of dilating the proximal capsule with a 1.5 balloon. It's not high because you are in the vessel.
Jeringa para inyectar contraste de rosca de
Chattering, so it's not. I think it's a quite safe procedure to do that, and because you need to have the Sasuke more at the bifurcation, more not so distal from the bifurcation to be able to go to the side port and enter the true lumen.
Okay, as you can see, I'm doing surfing. I'm from the school from Stefan Rimfred, who always does surfing, but this time I'm going to inject proximally before changing the septal with some contrast just to make sure.
Which wire are you using, Ignacio?
That was Sion.
Sion, okay.
Do you suggest Suo, trying Suo here?
I think so.
No.
Not Suo? Why Suo?
Not everybody agrees.
No.
Okay, let me do cine here.
Because you need support. You have a previous stent vessel. You need more. Probably cyan black. It's not a bad option in this case.
I will try a couple more minutes this septal, and then I will move to another one. Sí, Almedas, ¿verdad?
Nacho, another option is if a retrograde approach is not possible, another option is to check and to look for the true lumen with the IBU. It's not easy.
Sole, but I could not advance the IBUs any further, so I should do dilation for that.
You will have to dilate the proximal part of the artery pass the IBUs. It's not to look for the true lumen with the IBU, but is the last resort if you don't have other possibility.
So before doing that, I would do the knuckle, I think, before doing an IBUs guided function, I think. Yeah.
No IBUs function.
We have a suggestion. Sorry.
To guide
Sorry.
No, to look for the true lumen inside of the occluded segment. It's a Japanese technique. It's difficult to orientate the guide wire with the IBU, but we use this technique sometimes as a last resort.
We need you here, Sole, for doing that. I find it very difficult to...
No, it's very difficult, yes. But when you don't have other possibility.
Vale, voy a cambiar de septal. A ver.
We have a suggestion from the audience, from Dr. Walter Linus, agreeing with João Silveira and suggesting a cyan black.
Cyan black in the septal?
Yes.
Yes.
Okay, it's a good suggestion. Cyan black,
yeah, it's good.
We are going to try, and if it does not work...
First approach is cyan black. Yeah.
Es que viendo dónde se dirige esta, yo veo que la otra septal era peor todavía.
¿Tienes un test ahí, por
Era
favor?
muy septal, sí.
It goes very distally for being the first septal.
Yeah.
Okay, so I think I have to remove it from this septal and try the next one maybe. Okay. Okay, vamos con la cyan blue primero para entrar en la siguiente septal. So I have already bended my cyan blue to enter the... Perdón. So your suggestion for next steps are trying the septals with cyan black and then trying to do IBUs guided function or knuckle, right?
La que acaba de sacar la...
Yeah.
La cyan...
At that point, you need to know if you want to start with some plaque modification in the proximal portion of right, and after that, if it's control not to extend dissection for at that point you finish the procedure, and it will be in the safe fashion. You can advance our trap liner or trapping, and you can do more distally, and you can function better. At that point, you need to modify or to do knuckle. Probably it's a safe way to do this at that time this procedure. Or you can, if you advance with the knuckle, you can try with the stingray in function with distal vessel. Again, it's not a straightforward procedure.
I have a question for the panel. Do you usually use, when you go with the trap liner, large trap line like 8 French, 7 French, or you go with the 6 so you can advance a little bit further? Because there are people that use all the time 6 French, and you can use crossbows and stingray with 6 French. So I don't know your experience with that.
Very good questions. I think to me, we use 6 French trap liner, and you can perform your crossbow stingray in 6 French, which is quite. I almost never use 8 French actually. I use always 6 or 7, and for trap liner, 6 French is quite is a very useful option.
Because we don't have it in the shelf, actually. We only have 6 French, so I don't know if it's useful to have also, but I don't have experience with that, so that was why I'm asking.
Yeah. 6 and 7 are very useful. 8, you know, I don't see a real use to 8 French, but 6 and 7 top line are very good to me.
Yes, but regarding the protection of the submittal space, do you think the 6 French should be enough?
No, usually it does the job. You go deep with it, and it does the job. To me, 6 French is enough. You know, it depends if you got a massive artery of 5.0, but usually you put it in the proximal cap, and there is no flow in the artery beyond this. So in practical aspect, it's okay.
Sometimes it's not possible.
Yeah, if you can advance it, yeah, obviously. Yeah. But over a balloon, you can usually advance it as a standard guide extension catheter, you know, as you do for Godzilla, Guideliner, any other.
Okay. I think we are on time now to have the second presentation. João, I would ask João to present his talk about managing calcium in CTOs. Are you ready, João? Yes.
Okay. Good morning, everyone. Thank you very much for the invitation. My talk is how to handle with the calcium CTO procedure. As you know, the calcium is in the CTO procedure. We have an calcium paradox because as interventional cardiologists, it's our major enemy. But in the CTO procedure, it can be a good friend because you know every time if you have to do if you are in the vessel a Cto, it's very important point. We need that in CTO PCI we have a lot of heterogeneity, and the long occlusion generally require optimized as well strategy, and sometimes you need alternative approaches for this type of lesion because it's a heterogeneity of the vessel in histopathology. We need first point, it's very important point, but this is probably 40 or 50% of the success of the procedure. It's guiding and support you different sheets, different guide, long guide, passive support, active support, but it's very important to look at the natural or the problem that you have, because we have a lot of classification. We tried a guide exchange and a catheter, but the support in this procedure, it's a major problem. The first point, how can I optimize my support? I'm going to try to talk about the RCA. Probably it's the best guide for this approach. It's IL guiding. This is the more support you have, but sometimes you need to be careful because you have take some risk and dissection and stop the procedure. After that, you need to use, as everyone knows, probably you got a regular guide extension. You can use guide extension and balloon at trap line at 6, 7, 8 French. After that, you need the micro catheter. This is a good point. It's a good evolution to approach CTO, and you need to know very well which tip the wire we need to select, and also to increase support you need to anchor. But once again, this is the most important me for the planning the procedure. When you are talking with the guide wires, you need to do clearly what is the task of my guide wire and what is the properties of the micro guide wire. I need to understand when I planning my procedure. At this point, if everything is okay, at this point you are going to succeed at the end. What we have learned from the modulation of the guide wire, we need to lead first of all with the proximal cap. This is sometimes the most difficult part of the procedure because you have a lot of heterogeneity, a lot of classification, a lot of ambiguity behind. You need to palpate the proximal cap, and sometimes you need to penetrate the proximal cap. in few words, you need to palpate, you need to penetration, and you need to find space, and you need to make space. And to me, this is why you can do some progress if you do this. In the CTO PCI with calcium, the most important task that you need to wiring the proximal blunt cap, and you need to navigating in the calcium. This is the good point of the properties of the wires. And when we have a blunt proximal cap, what you need the penetration wire, heavy tip loaded, and very, very important, probably one of the best, it's the Arnold 14 and CP12. This is all the time working. This is 87 years old guy. This came with angina class 3, very symptomatic. It's a flash occlusion of the LAD, heavy calcified. We try filter XTR, we try fighter, but it's not succeed at that point. We try with the support of the microcatheter. This is a regular one, not a forced microcatheter. And Arnold 14, the guide wire jumping for the diagonal. It's something that with some stress in the room, because you can interruption of the diagonal. But it's a good point that the calcium, it could be a friend, because I know very well where I'm at. This is a heavy calcifying LAD, 87 years old guy. But at the end, it's easily and safety. I finished the procedure with the punction, with the high direction of the Arnold 14, advanced the microcatheter with the exchange wire, and finish the procedure in a very easy way. And at the end, we need the choice of the guide wire that should reflects the anatomy. Anatomy, as everyone knows, this is an anatomy that define what is the initial strategy. Okay, we need to wire a blunt proximal cap. You need penetration wire. We need to wire loose tissue with CTO, because with de-escalation and de-escalation, and doing the segment, you need to do penetration wire. This is what is very important when you need the regular microcatheter, or not the high penetration microcatheter, or Tornos or something, the turnpike load. You need the load and the penetration for. This is the interaction, because the microcatheter and the guide wire. This is a very important point we need to keep in mind. And when you are walking the proximal cap, this is uncrossable proximal cap. Probably it's one of the causes of the failure of the procedure. We have a lot of the approach that you can take, but probably use different ones. You need to choose. You need you need probably 80 proximal cap. Once again, you need to me or not? Can you hear me?
Is your connection good?
I'm hear you very well, and I could see you very well. That's
yes,
okay?
But we have some interruptions.
Okay.
Yeah. Just one slide back.
Connection. That's okay?
Yes.
This is undilated proximal cap. Once again, it depends if you want to be more aggressive, but sometimes you need to be more aggressive. More aggressive, it's things that you can pay something for to finish a procedure, or for to turn this procedure as an invested procedure. The microcatheters, once again, you need to understand the extreme task. Sometimes you even a general use microcatheter, but sometimes you need a calcium in the antegrade. You need to deliver simple delivery or threatened delivery. Sometimes you need the minimum torque transmission. Sometimes you need to max torque transmission when you are going through the CTO body with a lot of calcium. And sometimes you need some dilators, the taper of the microcatheter, the lobe ratios of the microcatheter, and the profile of the microcatheter. This is what you do in regular way, but when you you need trackability, but you need track and pushability, and we can succeed. When you are talking about the CTO PCI, you need the more trackability and the more push with the turnpike gold and the tornus. This is what you have. The high penetration microcutis and the turnpike goes advanced with clockwise torque. This is a very, very good device. It can help a lot in this very, very complex situation. And also tornus advanced in the T-clockwise rotation. What do we have in the plaque modification? And that show us surprisingly with IVUS imaging. We need to do some specialized balloons as spotting balloons, Wolverine, the new one. You have a better profile of the balloons, but also one of the balloons that it's very, very good. It is OPN balloon. You can go up and you can go very up in the pressure and the calcium. Also, we have some different approaches for the plaque modification, as you have a rotor flow. This is a very good innovation. I don't have any experience with orbitalectomy, but you have Chokewaves, IVL. It's a good and safe for to do the preceded and the laser. I'm going to show you some cases. This is a 6-year-old male guy with hypertension, dyslipidemia, diabetes, non-insulin required. He was submitted a CABG in 2014 with limit to LED, aortic obtuse marginal with free graft with RIMA. He came with us in the GINA class 3. When they performed the stress echo with the inferior ischemia, you have a coronary angiogram with 3-vessel disease, LAD CTO, left syncoflex CTO, and critical stenosis of MR CTO. And our strategy is to go to the CTO. This is not critical. This is different because it's critical stenosis of CIRC and the RCO CTO. This is a dual injection. This is a short occlusion, heavy calcified because we did IVUS in this case, but it's an ambiguous sampling. This is our primary strategy is to do antegrade wide escalation with the with the coster to track the plaque, to try to track the plaque, to advance the Corsair 135, and we reach the vessel. After time you do Chockwave 3.5, stenting post dilatation with the OPN balloon with 3.5. This is our final result, because at that point you need to do some IVL in this portion of the artery because it's not well, because we did IVUS in this case, it's not well expanded. We have more than 260 arch the calcium. This is our final result. Another case, this is a 75-year-old male smoking, hypertension, dyslipidemia, and diabetes, insulin required, angina class 2 in June 2021, and the 3 vessels, LA CTO, proximal RCA CTO, critical stenosis of the circ. You was turned down for the caves, and we decided to do CTO PCI of LAD with IVUS guided. This is once again, this is a short occlusion, but you have a post occlusion aneurysm and a lot of calcification, RCA and also in the LAD. We did the obviously, it's impressive, the massive calcification after the aneurysm dilatation and the very complex procedure in the aneurysm. Our target is to do a spot stenting just in the line. This is why we choose IVUS to understand the vessel, but also understand what is my distal landing zone. It's very, very limited stenting approach, because it's for to do the rotablation. It's high risk, because don't forget that the RCA was occluded also, and this guy was turned down for surgery. This is our problem. It's in the left, you have a dilatation, but you have a severe calcification in the big vessel as you can see in the proximal portion of the vessel. This is some problem with the support, but our strategy, we try to do integrated wide escalation with the field XCR, CP12, and 110. Do the strategy. Then second, we use the squatting balloon, Megatron 4 by 24 PN. Another case, it says that 70-year-old male, dyslipidemia, hypertension, diabetes, myocardial infarction, and stenting LAD, and left circumflex and of first obtuse marginal angina in April 21, and he performed the myocardial perfusion scintigraphy with inferior ischemia, and the left ejection fraction was 52%. And we performed the angiogram and three vessel disease, mid LAD CTO, mid RCA CTO, and left stenosis, critical stenosis of the left circumflex. Was done also for 2 cabbage. And this is what you find. This is a heavy calcifying LAD, the stent in the proximal LAD, it's okay. But in the circle, we have a lot of disease, and you can see very well the calcification. It's a problem. It's the backup support. It's bad because it's a takeoff, and we need. And at that point, we decide to use upfront the guidezilla. Use fighter pilot to end at sign black, and finally you puncture the vessel, the occlusion with the Gaia second. This is what he did: fighter, turnpike spiral, and Gaia second. And you track easily the vessel, and the safe way you can see in the. This is the next position. Advance is tapping now. Change wire for the cyan wire, tapping balloon. We did this shockwaves assistant guidezilla because it's very difficult. You can see in the left panel. This is very difficult because you look at the catheter, and also it is possible just to increase the support with the microwave. You can do the same pulses in the right panel with the guideliner, the guidezilla assisted shockwaves. We did a lot of lesion preparation of OPN balloon, the scoring balloon, and this is our final result. My take-home message: classification in a CTO, it's within the total occlusion, is an independent predictor of percutaneous coronary intervention failure. It can turn the procedure prolonged in duration. Suboptimal stent expansion and complication in this type of this procedure is a key characteristic in CTO complex scores, as you know, knowing. Calcium is most common in proximal cap, also frequent in the body of CTO, but also in the distal cap, particularly in the post-CABG patient, because it's also very prevalent. Our studies, we have a 25-30% of the cases as post-CABG patient. This is very important point to optimize the spot. This is the key for the success of the procedure. We need to know very well our task and the properties of the guidelines for to do this procedure in safe and efficient and efficacy points. Microcatheters and guide extension are very, very important tools. CTO can be crossed by tracking, intraplaque, or by dissection re-enter around occlusion in less resistant subintimal space, as you know, in our definition, we know you need to talk about intraplaque and extraplaque with a new definition of ARCH CTO. Plaque modification, it's a very, very important point in the very calcified lesion. And as Pierre, excellent presentation of Pierre, the intravascular imaging is needed. It's very, very important because it turns the procedure safe and turn the procedure long-term follow-up of the patient. And at the end, I can conclude that almost every lesion can be treated, provided you have the right skills and the right tools. Thank you very much for your attention.
Thank you, João, for your nice presentation, and it was very clear. I would like to make some comment. I can see that you didn't spoke about rotablator. I know that you are not a fan, but I have some good experience with the use of rotablator in uncrossable lesions, and I would like to hear Pierre, because I can see that he's also using, about his experience, about the difficulty in moving to the rotawire, and also if he had some bad experience, because sometimes we are not sure about being in the true lumen. What is your experience, please, Pierre?
I think we have a presentation where we are going to talking about the rotablation. This is why we have some cases, but this is why I didn't talk about rotablation in this case.
Okay, yeah, I was about that later on.
Yeah, this is the problem.
Okay, no, I was commenting because we discussed that, and I know that you have some doubts about using rotablator, and that's why
the problem you must need where you are. If you are intraplaque, if you are extraplaque. After this point, once again, this is for the safety reasons, because as you know, now with new RotaPro, you can do more and more and easily to team and to prepare the device. It's very safely if you have a good indication, but you need to respect the vessel and the calcium. You need support. You need again the safety of the procedure of the time.
Okay. And does anyone from the panel want to make some short comment? Just
I think just to comment this issue of rotablator, that it is safe to do it in CTO procedures in dissected planes. That is one possible concern, but I agree with Joao that you should know if you are intraplaque or extraplaque, and probably you have more complications that when you use rotablation in other scenarios. But I'll show you later some data about it.
Okay, thank you. So maybe we could.
But this is the same. This is the same. Pedro, can you hear me? This is the same when you use IVL, because sometimes you have some problems. If again, are you in intraplaque or are you extraplaque? You can take some risk. This is the most important point you keep in mind. You need to know where you are and what you want to do. What is your task? What is the properties of your devices? This is the most important point. At that point, as Pierre showed us, the role of intravascular imaging, it's the key for the procedure. This is very important point.
Yes, but the question is that if you have an uncrossable lesion, you can't see. You can use.
You need to do something. If it. Okay. If you can understand the lesion. Okay. Look at the natural cases. Okay. Now you have a lot of information. You know why the RCA is ischemic, because we have a arch of 360, a ring of 360, the calcium in the proximal portion of RCA. Probably you need to do something different. And when you engage deeply the triplan and you are turning the hemodynamic instability, the pressure are not good, hypotension too in the low flow in the LAD. Okay, you need to take some decision, but you know what is the problem with this procedure? Why this procedure go forward? Why didn't he have some progress? Because you need to think about sometimes. Okay, stop. I'm going to define a new strategy, because it will be probably a failure mode procedure. This is, you need to go out of the failure mode very early in the procedure, because you try one strategy, fail, another strategy, fail, another fail. Sometimes the people are so tired about the case, you take some risk. Now, when they go out of the room in the Valladolid, they use more than 300 cc's of the contrast. Okay, you are not. You are going to have some safety concerns to finish the case in the efficient and efficacy. Some concerns about the cases.
Okay.